Hi, everybody. I'm Sarah Compton. I'm research faculty in obstetrics and gynecology, and I am thrilled to be here to introduce Alison Norris. Dr. Norris is an epidemiologist and a medical doctor who studies sexual and reproductive health with the goal to support reproductive autonomy, excellent reproductive health outcomes, and prevention of sexually transmitted infections. She has particular interest in understanding how policy, endemic disease, social norms, demographic factors, and cultural and institutional structures influence health and disease. Dr. Norris has been at The Ohio State University since 2011, currently chairs the Division of Epidemiology, and holds courtesy appointments in the Division of Infectious Disease and the Department of Women, Gender, and Sexuality Studies. Additionally, she co-leads a collaborative research program called the Ohio Policy Evaluation Network, or OPEN. And if anybody else struggles to come up with fantastic acronyms and titles for things, I would say I really enjoy that one. And with that, the goal of OPEN is to understand how laws and policies impact access to abortion and contraception. And she also co-leads the research steering committee for the We Count project, which is a national effort housed at the Society for Family Planning. It measures the impact of the significant changes in abortion care following the 2022 Dobbs decision. And we are so thrilled to have you. Thank you for coming up.
Thanks so much, Sarah, and thank you to all of you for inviting me here today. How is the audio in the back? And someone on Zoom can say if it's okay. I can't see you on Zoom, but I know you're there. Thanks again so much for having me here. As Sarah said, my name is Alison Norris, and I'm in epidemiology at Ohio State. I'm going to talk to you today about abortion access in Ohio, and I'm going to share findings from OPEN, the Ohio Policy Evaluation Network, which was named by one of our graduate students in our first, we had a competition, and they won a $50 gift certificate for that name, but I think probably we still owe them a little bit more. We're very happy with the name. I co-lead OPEN with Danielle Bissett, who's at the University of Cincinnati. And okay, beginning here. Let's see. Okay, I think, here we go. Okay. So many of the scholars who work with OPEN, faculty, staff, and students are based in Ohio. And we also have collaborators across, all across the United States, particularly in the Midwest, and including right here at University of Michigan. Our mission is to conduct and translate rigorous and forward-thinking social science research about the policies and structural inequities related to abortion and contraception. And we focus on Ohioans and people in neighboring states. Given the increased disparities and increased lack of abortion that resulted from the Dobbs decision, and the very real possibility that access to abortion is going to get even more complicated in the coming weeks if the Comstock Act is enforced, I decided to share with you today a more uplifting story of research being used as evidence in the changing of policy. So first, I'm going to take a step back. Some months ago, I was listening to an interview with the brilliant Tiffany Green at University of Wisconsin. She was speaking at the time of the Dobbs decision, and she put it very clearly. The effects of limiting abortion access have been very well established. Limiting access can lead to poor pregnancy-related outcomes and other poor outcomes, and those bad outcomes are experienced more by Black and Brown and Indigenous people. On the global stage, we see a simple and direct connection between abortion and mental health, maternal health. Globally, unsafe abortion contributes as much as 14% to maternal mortality across the world, and 97% of unsafe abortions take place in lower income countries. Here in the US, very, very few abortions are medically unsafe. This very small number could increase to a larger, very small number in states where abortion is banned. And people who still need to terminate pregnancies find themselves in desperate situations. The reason that the safety of abortion in the US, even when it is not legally accessible, is that medication abortion, which can be self-managed, has dramatically changed the landscape of abortion safety in contexts where abortion is hard to obtain. Abortion outside the formal healthcare system is much, much safer than it was 50 years ago. We have some limited, oops, okay, it's still, okay. We have some limited direct measures of abortion and maternal health in the United States. One comes from the Turnaway study. 1,000 women were surveyed prospectively for 5 years. In this study, 500 women were enrolled within the gestational limit at a clinic where they attended for care, and they had an abortion, and 500 were just on the other side of the gestational limit of the clinic that they attended, and they were turned away, which is how the study is named, the Turnaway study. The women in the study who went on to give birth reported potentially life-threatening complications such as eclampsia and postpartum hemorrhage, whereas those having abortions did not. One participant died due to complications from delivery. In addition to the death, the Turnaway study clearly articulated health and economic impacts on women who did not obtain an abortion that they continued to experience even years later. We have other data that are more indirect population measures of abortion safety. Some of these data are really old. Raymond and Grimes estimated deaths resulting from births and from abortions that happened in 1998 to 2005. Those data are starkly clear. The risk of death due to birth is 14 times higher than the risk of death due to a safe abortion. Over the past 20 years, safety of abortion has improved. So in short, the riskiness of death from staying pregnant is much greater than the riskiness of death from abortion. We have other new scholarship from Amanda Stevenson examining what would happen if the US, for example, had a total abortion ban and no one in any state could obtain an abortion. She analyzed state by state and for white and for Black people separately. In summary, in the first year of such a ban, the estimated pregnancy-related deaths would increase from 675 to 724, so an additional 49 deaths. And in subsequent years, another 140 additional deaths per year. Non-Hispanic Black people would experience the greatest increases, in fact, a 33% increase in deaths in subsequent years. And new findings from Alison Gemmell and Parvati Singh show worse birth outcomes for infants as well post-ops. So in addition, it's not correct to imagine that people had amazing access to abortion before Dobbs and before bans came into place. There are trap laws that cause clinics to close and make access harder for people, particularly in rural areas in dozens of states. Mandatory waiting periods and bans against using public insurance for abortion increase the travel and cost barriers to insurmountable levels for thousands of people whose number we have never been able to know. It can help us to consider what access looks like for people who do have resources and privilege. In short, abortion is available to them. They have money to travel, money to pay for an abortion, flexibility to take time off work, resources to manage childcare. And the converse is also true. People who are most impacted by abortion restrictions are poor, have tough work schedules, and given the way our society is structured, those people are more likely to be Black and brown and indigenous. So barriers to obtaining abortion care line right up with the barriers to obtaining contraceptive care and the barriers to pregnancy care, and broadly speaking, the barriers to all health care, and they're rooted in the concentration of wealth among the few, the lack of truly supportive set of welfare programs and policies, including universal health care, and the concentration of political power among the few. And of course, racism, which systematically denies whole groups of people access to economic and social resources. So the takeaway from all of this is that abortion access is more limited for those who have the least access to a variety of resources. And so as we see bans in place or any kind of restriction in place, the disparate impact of those is always also occurring. Okay, so despite this, all these bans and restrictions, abortion is super normal. In the United States, more than 1 million people had an abortion in 2024. It's common in Ohio, of course, as well. 20,000 people receive abortion care in the US every year, in Ohio every year, despite having quite a number of restrictions, which I'll show you. And as we know well, abortion is essential to health and well-being. So, okay, this is sort of the big context. I'm going to show you a tiny, small example of where in the state of Ohio we are seeing a policy move in the opposite direction. And the open research team contributed some evidence in the making of this policy change. Here is an idealized version of the intersection between data and policy. This is what we would like to have happen. Let me pull out now to tell you what is happening in Ohio. So while most Ohioans support abortion, we live in a state with many, many abortion restrictions. I think I have a slide just here. This is a snapshot of abortion laws in Ohio, but over a 10-year period. And there are restrictions on like sort of every dimension of access to care represented here. So how did we get there? Well, 75% of Ohioans live in districts where elections for state representatives and state senators are not in dispute. This is because lawmakers draw maps to favor, in my case in Ohio, lawmakers drew maps to favor Republican candidates by disproportionately placing Democrats in the toss-up races while shielding Republicans from competition. This is called gerrymandering. So it's, gerrymandering is a hotly contested, whether it is legal and how it can be managed by lawmakers. In 2022, the Ohio Supreme Court ruled that the congressional map was unconstitutional. However, the lawmakers declined to change the map. In 2024, voters had an opportunity to vote on a ballot initiative for a new constitutional amendment to replace politicians with a citizens redistricting commission, but they rejected that ballot initiative in Ohio. So we remain with a very highly gerrymandered electoral map. And what happens to lawmakers in districts where there is no competition between parties, there's a competition then between the people within a party. And in Ohio, at this time, both to secure votes and funding, candidates will often run farther to the right than they would if they were seeking a broader constituency. So some of the anti-abortion beliefs put forward by elected officials in Ohio, some of them are sincere. There's anti-abortion beliefs from prioritizing a fetus over a birthing person. Those can be sincerely held beliefs. There are some sincerely held anti-woman beliefs that lead people to have anti-abortion stances. And then some of them are really not sincere. They're anti-abortion beliefs professed from wanting to be the more conservative person in the race. Hence, we have this really incredibly dense set of legal restrictions against abortion. Okay, I want to talk a little bit about the 24-hour waiting period. So in Ohio, lawmakers passed a 24-hour waiting period for abortions in 1991. Around this same time was, so did Pennsylvania. Pennsylvania had a constitutional amendment passed in 88 and 89, which required, among other things, a 24-hour waiting period. These regulations in Pennsylvania made it all the way to the Supreme Court, and in the case Planned Parenthood versus Casey, in which case the 24-hour waiting period was deemed to be constitutional. And this is also where the undue burden for a person seeking abortion care was. That legal case was laid out. Of course, Planned Parenthood and Roe are both overturned by Dobbs, but this is sort of the history of the 24-hour waiting period. So Ohio has had a 24-hour waiting period, and then we updated it in 1998 to require that the in-person visit be required to begin that waiting period. I've shown you this slide of our myriad laws, and the expected impacts on access. The impacts on access are, as expected, greater for younger people, poorer people, people with structurally inequitable access to healthcare, which includes people of color and rural living people. Then I have a slide here to show you what happened in our region when the Dobbs decision came down. Ohio, on the evening, the Dobbs was decided on a Friday morning. By Friday night, a 6-week ban, which had been passed and then put on hold by the courts in Ohio, was free to be enacted. So Ohio had a 6-week ban starting on the night of that Friday night in June of 2022. And then, but of course, also in our ecosystem, states were having trigger laws passed, passing laws in the legislature, having those overturned in the courts, and the ecosystem was like intensely dynamic. So I'm going to show you a slide, and what I want you to keep your eyes on the top is going to be the date, and this is a week-by-week slide for 6 months, and the colors represent the availability of access in the states. Okay. So here is the date. You can watch it changing. And then these states are like losing access and gaining access in Indiana, Kentucky, West Virginia. Michigan stays a nice light blue the whole time. This was an intensely confusing time for providers, an intensely confusing time for patients. There was tons of misinformation and also tons of true restrictions that were hard to know how to manage. By the time we come to the end of 2022, where this little video stops, we land, I think, at the situation that is currently today. Although, no, I'm wrong, because Indiana now has a total abortion ban. Yeah, so this is what, if Indiana is, no abortion is legal in Indiana, and otherwise, it hasn't changed much since the end of 2022. Okay, so there are data from many studies that show the impact of a 24-hour in-person waiting period. They are present now in many, many states, 23 states, and Washington, D.C., people can obtain an abortion on the same day they present for care. It's actually a very ordinary thing, and for reproductive age women who live in those states, the majority, that live in a US state that allow abortion, the majority experience no mandatory waiting period for abortion. In Ohio, the law required people to wait 24 hours between the in-person consent appointment and the abortion appointment. The American College of Obstetrics and Gynecologists states that waiting periods and multiple appointment requirements are not medically necessary, delay access to abortion, and threaten patient safety, in part because of those delays. And there's a considerable body of scholarship demonstrating the harmful and burdensome impacts of such laws in the US, including increasing cost and resulting in patients being unable to receive care at the facility they choose or within the state where they reside. So we decided to compile the data that we had been collecting to look specifically at the impacts of this 24-hour waiting period. At the first informed consent appointment, physicians had to deliver state-directed counseling using state-generated materials, perform a state-mandated check for embryonic cardiac activity, usually via ultrasound, and each of those steps had to be in place before the patient provided consent for an abortion, and there's no medical evidence that suggests that any of this counseling or these materials or the cardiac activity check advances individual health. There was no possibility of opting out of these activities, and they were against the medical standard of care. So a 24-hour waiting period doesn't sound so onerous in some, like it could be like, well, doesn't it sort of nice to have a chance to think a little bit about an important decision that you're having? Like there's some, in the ecosystem, maybe no one in this room thinks that that's true, but in the general public, it's not so sort of radical to think someone might want to have a 24-hour waiting period after consenting to have this medical care. So one thing that we decided to look at first was how long do people actually wait? There was a master's student doing her thesis with Open, and she began looking at data that we had collected from a chart review of abortion clinic patients from 2014 to 2018. And Given all of the chaos in the ecosystem right now, I will not share this brilliant student's name. So it's very simple what we were decided to look at. Like how many days between the first appointment day would have been day 0, the consent day, and then everybody could have had their abortion the next day because 24 hours would have been completed by that time. And then we looked at what the distribution was in terms of how long people actually waited. I wonder if anyone would like to hazard a guess how many patients returned, or even approximate, like a third, or what do you think? What do you think of half? What proportion do you think of patients returned the next day for their care? You are pretty close. 6. Yeah. So only 6% of patients returned within 24 hours. And then looking into the first week, people are kind of spread out across here. And this represents about half. And it turns out that half of abortion patients during this 5-year period of time, well before Dobbs, and well before some of the other abortion restrictions that are present in Ohio, before they could have their abortion care. So 24 hours is not really 24 hours. We also looked at the social and medical impacts of waiting. So here, a participant in an interview that we held with an abortion patient. Every time I had to go, I had to get a babysitter. What if someone sees me? What will the protesters? I had to go multiple times. So this is also not a person who lives where the clinic is. So each one of these visits, she's getting childcare and arranging and getting up early and driving an hour or 2 hours and round trip for each appointment. And in a totally unnecessary medical sort of, or let's say legislative or a legal ecosystem, policy regulated ecosystem. In a survey that we conducted, patients identified the multiple trips as being part of the burden that they experienced. And patients see it as the multiple trips. Those multiple trips are required because of this 24-hour waiting period, right? So maybe a little harder to, those things are coupled in people's experience of them. And then this is from an interview with a clinician. So now we're talking about patients who are at some gestational cusp. So this is at the gestational cusp where they no longer can get an abortion in Ohio. They're right at the edge of the possibility of getting an abortion in Ohio. So this idea that they have to go and have a scan and come back again, and if they can't come the very next day, in fact, if the average number of them is waiting a week, all of a sudden they are bumped beyond the gestational limit of abortion in Ohio. But there's other gestational cut points in terms of what method of abortion you can use, the cost of the abortion, whether people are going to want to, pain management, like all these things change over time. The riskiness of an abortion changes over time. So these delays drive into all kinds of social issues, cost issues, logistical issues, and medical safety issues. Okay, so we as I have said before, also were able to document that these kind of disadvantages or stresses on people's lives are experienced most difficultly by people who already experience the most structural disadvantage in receiving healthcare. So then we had this sort of amazing, okay, so I described we had this legislative sort of wild legislative experience where we had more than 20 pieces of legislation that restricted abortion access in all the different possible ways. Dobbs' decision came down. We had the 6-week ban in place for 3 months. Then we had a temporary restraining order. But with Dobbs, there became this sort of flood of political activism. And there was a ballot initiative put forward called the Reproductive Freedom Amendment to the state constitution that protects contraception, fertility treatment, continuing one's own pregnancy, miscarriage care, and abortion. And the Ohio voters turned out, and it passed 57% to 43%. So kind of an overwhelming vote for something that was not necessarily, well, something which in terms of our legislative environment, you might have imagined was the constituents had a very different point of view. So we see that there's a pretty big divide between the lawmakers and the voters. So this was tremendously good news. The district, so we passed in Ohio the Freedom of Reproductive Freedom Amendment in November, 57 to 43. And then the Attorney General could have said, well, clearly these myriad laws are unconstitutional given the new constitutional amendment. That's the job of the Attorney General, is to make some of those decisions. Instead, he said that every single one of the abortion restrictions would need to be challenged individually in the court to remove them from the Ohio Revised Code. And here we will see some of the opportunities about the balance of powers playing out in what happened next. So the abortion advocates of both from all sorts of different parts of Ohio. So sometimes it is the reproductive health care providers themselves, sometimes it's advocacy organizations, sometimes groups like the ACLU are bringing forward and filing lawsuits to challenge the restrictions. And you can only challenge more than one at a time if they are related in nature. And this is what happened with I was sort of describing how the 24-hour waiting period and the in-person requirement are really quite linked. And so there was a case. We knew a case was brewing about this because providers had said for a long time that this set of laws was the most burdensome on patients. And so our research group put together a white paper that included the data that I showed you earlier and more to demonstrate in Ohio the impacts of abortion, this particular set of abortion restrictions on patients. And it can be useful to, even though the larger, we didn't need to show these data to prove that this was true because other scholars had demonstrated in other contexts, and it would have been naturally possible to extrapolate to the Ohio context. Nevertheless, if you're fighting a local law, it's useful to have local data. It's more compelling, especially to non-researchers who may have a little harder time making that leap. So when you are advocating, as I know you will have the opportunity to do, give the big data points from the literature that you understand as an expert, and then find some forms of local data to give the examples that the lawmakers and judges can sort of hang their hats on. In March of 2024, a lawsuit was brought forward challenging the in-person visit in the 24-hour waiting period. This was actually the first lawsuit brought under the new Reproductive Freedom Amendment. So it was like people were both excited that it was happening and nervous. It was the first test of this new constitutional amendment. Several months later, in August, the court granted a preliminary injunction, which means that the law is put on hold, and patients in Ohio can now access abortion care without having to navigate this 24-hour waiting period and in-person requirements. There was like kind of a mad scramble at the time of this decision. One thing that some colleagues and I have been very interested in is this idea of abortion care churn, which is that every time there's a new piece of legislation passed, all the clinics and therefore all the patients and all the advocates have to figure out how to navigate this new thing. Even every time a new law is proposed, there becomes this sort of churny experience because it's reported in the media and people think it might be already true, and the providers have to start getting ready for it. And so there's something happening now in some states where undoing restrictions also causes churn. I mean, it's kind of the churn that everybody wants, but it's also comes with a cost and some information to manage, and it's basically sort of reminding us that undoing harmful things is also hard, even if we're more motivated to undo harmful things, of course, than we are to have to implement them. The Ohio Women's Alliance, which is an advocacy group in Ohio, brought forward an amicus brief, and these data that I was showing you from the white paper were part of this amicus brief. And then, as I said, in August, the 24-hour waiting period was put on hold. The waiting period is gone, access is better. It is still compromised, and I want to talk a little bit about what's happening now in the ecosystem in Ohio. So more lawsuits are being brought forward. In fact, we just had another decision. There's one about disposition of fetal tissue, which was kind of actually had never been enacted, but it was one that would have cost clinics a huge amount of money and put a really big social burden on patients having to make decisions about the disposition of fetal tissue. That was, I mean, so cruel. So that one just got another temporary restriction placed on, a preliminary injunction placed against it. Whether the 24-hour waiting period, the fetal tissue restrictions, whether they'll be permanently blocked has yet to be determined, and the Ohio Supreme Court will have the last word. During the November 2024 election, another thing that happened in Ohio, I mentioned already that the law to have a more constitutional approach to districting was not passed by the Ohio voters. In addition, voters elected an Ohio Supreme Court that has a majority of anti-abortion judges, which has not been the case in the recent past. And then there's kind of this sort of fascinating moment that's happened, which is there was a huge political turnout to pass the reproductive health protection amendment. And now there's a little bit of complacency. Donations to abortion funds have decreased. People sort of think that things will be okay in Ohio because we have the constitutional amendment. And it should be the case that things are better. But it maybe causes a little bit of a tuning out to some of the things that are happening at the federal level, or the fact that the Ohio Supreme Court could fail to sort of make permanent injunctions against some of these laws that are now against the Ohio Constitution. And there was an interesting phenomenon that isn't really sort of core part of my work, but it is the case that in some states where abortion protections were put in place by voters, in the very same election, or often in the next election, people were willing to vote for federal level senators and president who had strong anti-abortion stances because they personally felt protected by the amendment that had been passed in their state. So I leave you with a quote here, and then I have one more quote I want to share. So this is Stacey Abrams, which is kind of inspiring us to continue to do the thing that is our thing to do. My thing to do is to do research and figure out how to translate it for a variety of public audiences. Your own thing is your own thing, and you'll keep doing that thing to bring forward data to give us the possibility of living in a more just and free world. And then a final one, which I actually have on my wall, was written by Rabbi Tarfon 2,000 years ago, and it comes from collection from Jewish Talmudic sages that's called either the Ethics of the Fathers or the Sayings of the Fathers. And this is it. You are not required to finish the work, yet neither are you permitted to desist from it. So this is a collective. None of one of us is required to do all of it, and yet we are asked to stay in the work. So thank you so much for giving me a chance to speak with you all today, and I would love to hear what you all think about all of this. Oh yes, I think I might even know. Is it this? Yes.
Can you hear me okay?
Yes.
Okay. So I'm from Ohio. Also went to Ohio State too. So I have a couple of political questions. Growing up in the state, how much of this, if you know, how much of this has been in like the changes to abortion access have been influenced by Mike DeWine? Because it seems I grew up mostly under Kasich, and it seems like I don't remember much of Kasich's policy as I'm young, but as an adult, Mike DeWine seems quite extreme and passive at the same time. But I don't know if these it's very passive too. But I'm not sure if we saw like the start of these changes under Kasich, or if this is something that just like flipped under DeWine.
So, right, so she's asking about the earlier governor and then the current governor. Thank you for that question. So all the laws that I am showing you were proposed and then moved through the legislature, being voted on both by the Congress and the Senate, House of Representatives and the Senate in Ohio, and then brought forward to be signed by the governor. And so there have been, across all of this time, governors have been signing these laws, have been signing these bills into law. And there have been sort of juncture points where the laws were seen to be either too extreme or clearly unconstitutional, and the governor declined to sign them. And sometimes those were overruled by a supermajority of the legislators, so that it became law even without the governor's signature. And in more recently, the current governor has been willing to sign things into law that he formally vetoed. So he, like, sort of it looked like some of it is probably political expediency, like what does it seem is acceptable in the ecosystem. DeWine is he is quite I would say he may be one of these non-cynical anti-abortion people. Like, he's a very religious person. He's very has done programming on behalf of children. He didn't try to dial back Medicaid restriction. He's put out good programs for particular mothers with substance use disorder. Like, there are some more progressively sort of clustered policies that are pro-child that he has supported, and but I think his stance on abortion in particular is complicated because he is very personally anti-abortion, and so it has been, well, fascinating, right, to see what are the things that are politically acceptable and at what times. The fact that the constitutional amendment to protect abortion passed overwhelmingly might have made you think that the legislators would have scaled back their efforts, and it hasn't really happened. On the other hand, they have turned their attention to other things, and so there's been a real deluge of anti-trans law that has both been passed and signed into law and enacted, and things related to voting rights, and yeah. So I was saying, I kind of carved out like a singular win to talk through with you. Thanks for that question.
Thank you.
I have a question on Zoom. So Cindy asked, fantastic talk and such important work. Thank you. If time allows, could you talk about any work by Open incorporating travel out of state for abortion care? It's both important due to access, but raises touchy questions concerning policy and potential policing in states like Indiana, lending support for anti-care groups in states with better access to care. Both Michigan and Illinois have taken strong moves to ensure access, and the number of out-of-state residents obtaining care is rising. Thoughts?
Yeah, thank you so much. This is a great set of questions asking about travel. So we have looked at lots of different things, and have collaborated with Sarah on a paper looking at abortion utilization in Michigan following Dobbs, and in particular, one of the key pieces of it is looking at the travelers. We have a similar paper in Illinois. The number of out-of-state patients in Illinois increased by 100%. Oh, let me make sure I get the number. Okay, I can't remember the exact data, but there was a big jump in the number of abortions obtained in Illinois following the Dobbs decision, and all of the increase is due to out-of-state travelers. It wasn't totally clear whether that was going to be the case, and I think globally, there's not globally, like nationally, there's sort of more going on. When states do things to increase access, those things don't only help travelers, they also help people who live in the state who also experienced those burdens and bans and lack of funding. So people, it is the case that people in states that have more protections for abortion access are more able to get abortions than they were before. And at least in the early days following the Dobbs decision in Illinois, for example, almost all of the increase needs to be from travelers. So there's some sort of important policy things there, which is that now these states, surrounding states with abortion bans, are doing huge labor on the behalf of people in the states with bans, which itself can be a political thing to navigate, and financial and on the part of the medical healthcare system as well. Michigan played such an important role in the post-Dobbs time. As I said, there was, first of all, there was a 6-week ban in Ohio. Ohio had been a bit of a destination state for places that had fewer clinics and more restrictions, which included Indiana, Kentucky, and West Virginia. And so losing access in Ohio kind of bumped thousands of people to look elsewhere. And Illinois and Michigan were during that dynamic time and now continue to be incredibly important for destinations for people who live in Indiana and Kentucky and West Virginia, which all have total abortion bans right now. And when I say total abortion ban, there's often some carve out for a handful of people, but the number of people who manage those carve outs is extremely small. And many providers in those states and patients in those states are just not willing to navigate the things required for those carve-outs, and it's much less burdensome to travel to another state. So the care providers in Michigan who changed the practices in order to see more patients, facilitate, also when travelers come, they're more likely to be more sick, farther along in gestation, having gone through a really sort of traumatic experience of having something told something's illegal in their own state, they have to leave their state, and just sort of psychologically that's something to overcome. And so patients who come from afar are like sort of sicker and need more care as a group. And so it's an even sort of greater gift that providers have given Michigan. I feel like there's one other little part of that. Oh, I know, I remember what I was thinking. There's quite a bit of out-of-state travel for abortion care before Dobbs. Particularly in states that have abortion restrictions.
I happen to have the paper up because PPFA just signed off on it, so I think it's okay to share this now. So we looked at in the 3 Planned Parenthood of Michigan facilities that are closest to the southern border with Ohio, that the out-of-state patients in those clinics increased by just over 3 times in that time. And so it had been 383 in the year pre-Dobbs, and it was 1145 in the year post-Dobbs. So it was a huge increase in the number of out-of-state patients coming to Michigan.
You had a question?
It was basically the same one.
Oh, good. Yes.
Thanks so much for presenting today. It's really exciting to hear how much work Open is doing. I'm curious if you can talk a bit about, you're gathering and disseminating local data. So how are you making connections with policymakers, and what strategies have worked? And are there any that maybe haven't worked? What advice would you have for people who want to share their findings with policymakers?
Thank you for that. I will say it is a journey, and we are still on it, but I can share what we have learned. We have probably our closest connections are with groups that are doing public health and justice advocacy in the state. So they're not the policymakers, but they have different kind of levers around access to policymakers and around their sort of like public dissemination, so to speak more broadly to people who care about these issues in the state. And it also can be the case that like our place of work is figuring out what the research question is, collecting the data, analyzing the data, writing it up in a clear, compelling way. And then it can be a great strategy to put it then in the hands of people who have these other sorts of access and levers and can make different kinds of claims and tie it to other causes and things that are just not as available to that kind of like more staid, impartial, methodologically rigorous driven space that we are in the academy. So we actually embrace our space there and recognize that others will be able to use our data better than more influentially than we can. So those are the relationships we've really worked on. We have such a minority of legislators who would use our evidence to make the kinds of laws that would protect Ohioans that we haven't done as much work, direct legislator engagement. Although I think there's opportunity there, even just to be supportive of those legislators, even if they aren't going to get their laws passed. So that's, I think, an opportunity that we just haven't sort of completed or haven't engaged as much as we could. We do and have oftentimes researchers from Open testify to the state legislature. Again, kind of just like, I mean, this is part of the work that all of us in this kind of repros or any of these spaces that have been very politicized, it's more to say, if we do the research, then it won't be silence on saying that these harms, what are the harms from these laws? And it feels like, I don't know, kind of a neutered response to be able to only say, well, I can document the harms and that's it. But if I didn't document the harms, that's even less. That's just total silence in the face of these things being passed. So we have, that's sort of the motivator for doing the work and the motivator for giving testimony in the State House. Not that we think we're going to convince someone exactly, but at least we have not been silenced, contributed to the silence. And I'll just give a little pitch because okay, so two things you may also, I'll just tell you how it works at Ohio State so that you can see how it works at the University of Michigan. I can take a day off work on a day I'm going to go testify because I am not supposed to do political activity. I do not do political activity as part of my job as a professor. And so I sort of, formally ask for the day off of work and when I'm going to make up my work at another time, and I document that through the HR system, and then I can testify as an individual person. In fact, the university loves for its experts, including its students and faculty and staff, to testify as experts. That's the mission of the university, is to be contributing to the public good. So, but I cannot do it on the power of the university. So that's just one thing to figure out how it works within your own university. The other thing is to just go try it. First time we went and gave testimony, I was so nervous. Actually, I think it was the most nervous I had ever been in my entire life. I would have thought that knees knocking together was like a metaphor for nervousness, but actually my knees were bulging together. I was like, wow, that's so nervous. And when I stood up there, and I don't even remember, it's you send a testimony and you read your thing, it's 5 minutes only, the legislators are all sitting there. I don't have no memory of how that went. And then I sat back down, and then 2 weeks later, we gave the same testimony to the other house. So this time I had gone through it once and had a chance to actually observe myself doing it. And I was like, oh, it's kind of like teaching some undergrads who don't really want to be there. I know a lot more than they do. I mean, a lot more. That's the other thing. You feel like, oh, it's a senator or something. Yeah, but they're an expert, whatever. They're an expert, which is I don't know, tractor repair, whatever. People are experts in all sorts of things when elected officials. So I was like, okay, I'm an expert here. I can be calm. Then I'm going to ask them some question I cannot answer. any of us in this room could answer any questions put to us in these spaces around the thing that we've come to talk about. And the other thing is they didn't really care. They're like looking at their iPads, they're like looking up into space. And I was just like, okay, but I don't know how to do this. I'm gonna do my thing and try to catch somebody's eye, hope somebody's interested in. So do testify and do it once. The first time you do it, you might be very nervous. And after that, it's kind of thrilling, actually. Very well like that.
I have one comment and one question. So
Great.
you mentioned that that unsafe abortion is a huge contributor to global. I will say that the wide availability and stability, even at high temperatures of meso, has absolutely changed the landscape, even in low resource settings. That the contribution to maternal mortality is no longer 14%. It's so low.
Yes.
And
These data are also old that I was citing. They're like 15 years old at least.
Yes,
And
and
it's a
so it's
revolution for mesoprossal.
absolutely revolutionary.
Yeah.
And then my second question, and this is not, I don't really think that this is a serious question, but are there 24-hour waiting periods for any other things in Ohio, like a vasectomy, for example, something that is permanent that might be harder to reverse? Or might have a longer impact on a person's life, or say buying a firearm that could cause harm to other people, if the sanctity of life is the point of a 24-hour waiting period for an abortion. I mean, is there anything else that requires?
Great question, which is that we should be very evidence-informed about our waiting periods. There's actually some structural barriers to getting vasectomy in Ohio, so I'm sorry to say there's some parity in like access there, especially on insurance. The ACA does not cover vasectomy, so it has to be up to states to fill in the gaps on vasectomy care. But of course that won't happen necessarily for private insurers. So there's some real conscious, but I think what we can acknowledge more broadly is that there are fewer incentives for providing and having available excellent reproductive health care at every part, in preventing a pregnancy, in maintaining a pregnancy, in having a pregnancy if you experience infertility, in having safe delivery and raising your children in safe and sustainable environments like these. That is the space where the disinvestments and the overregulation is so counter to the evidence and to sort of supporting the health and well-being of people in the state. And so that's another thing I think that we can do as scholars is to draw the connections between those things so that people can see. Because maybe in one person's own life, they don't know how they're touched by abortion. Of course, everybody is touched by abortion, and the availability of abortion has improved many people's lives. But people don't always know it directly. But if we can help paint the picture of how these things are interconnected, we can build more compassion for experiences that people haven't had directly.
I have a question. So you all are kept very busy by changes in policy and the whiplash that a lot of us are feeling right now about things being put into place and then withdrawn and the difficulty of responding to that. If you could have your wishes come true and you could get other kinds of data or additional data to the kinds that you're using now, or additional ways of using those data, like if you had a team of research assistants, what would be your dream of other kinds of data that you might find useful in your quest?
You won't be surprised, I have 2 studies ready right now. Whoever's got the million, actually probably like 6 million. So there's 2. One, actually, I think we will be able to do. One is that we know from data from the WeCount study and from Guttmacher and from Open and from many others that when you have a total abortion ban or 6-week abortion ban, even these sort of waiting periods, we can see that like the numbers of people who get care changes. So with a 6-week ban, in many states, there's about a 50% reduction in the number of people who get an abortion. There's a 6-week ban. But what we really lack the data is who gets the abortion and who does not. We can make some assumptions based on other studies, but that's one thing that we are going to look at using chart review data from clinics from around that time, just to look at the proportions of people who got proportions of identities and of people who got abortions when there was and was not a 6-week ban in place. But I think that is, like we think about the We Count project, which counts the total number of abortions by month and by state, but we have no data on the characteristics of the people. So that's just an enormous gap in our understanding of the impacts of these numbers. The other study that we need is all of this work around, especially the quantitative work around abortion access. It is with the people who got an abortion, or at least the people who got to the clinic. And there are thousands and thousands and thousands of people who need an abortion but don't get to the clinic and they don't get enrolled in a research project. And sometimes they don't get to, well, there's all the reasons they don't get to a clinic, and some of them are even like, barriers that are related to their family or their like understanding of what's legal or available. It's not even necessarily barriers that we could measure unless they told us. So the study that I would really want to do would be to recruit people from the moment of pregnancy knowledge and just follow people over time and ask them what they're thinking about and what they consider along their journey. That would give us a huge understanding also about how people access the benefits they receive or don't receive from prenatal care and from their birth experience if they continue the pregnancy. But I think that unknown number of people who don't get an abortion for unknown reasons, those are the people I would really love to study. And like, I mean, I really thought a lot about this, so like being able to like give out pregnancy kits in the CVSs that have recruitment flyers in them. Haven't cracked that nut, but that is the study. One of you might. I'd love to be your co-investigator.
Dr. Norris, thank you so much for
Thank you.
this enlightening and such an important set of topics right now for all of us. So thank you so much for coming. Thanks everybody for your questions.